right, well, thank you so much. I really appreciate the invitation for being here today and excited for everybody who's put hard work into preparing this for it to go today. And I'd like to introduce Cecily Dupree, who is the Complex GI Surgery Fellow at Methodist Richardson. She has a couple really crazy cases for us to discuss today, and I think you'll find them really interesting. So Cecily, take it away.
Thank you, Dr. Pryor, and good afternoon to everyone. Yes, my name is Cecily Dupree, and I am the new designation Complex GI Surgery Fellow at Methodist Richardson. And I'd like to thank the leadership of the SSAT, Dr. Jayaraja, my mentor, Dr. Benzie, and Dr. Pryor for being part of this and allowing me the opportunity to discuss with everyone the surgical management of endoscopic complications in our Fellows Grand Round series. I have no conflicts of interest or that are relevant to this presentation to disclose at this time. And today, what I'd like to do first is review a brief history of advanced endoscopy, then get into a couple of case reports that will hopefully be interesting for everyone and interactive about the occurrence and management of complications after types of endoscopic or advanced endoscopic surgery or procedures. And then I'll conclude with some final thoughts and hopefully open the floor up to the experts to give us some further insight as we go moving forward as fellows. So the birth of endoscopy actually began in 1905 with a physician by the name of Bozzini, who designed what was the first successful endoscope using kind of external light sources and tubes. And this was reproduced in 1827 in the United States by John Fisher out of Boston, who had a similar instrument that used candlelight, tubular spectrum, and a series of mirrors to be able to see inside. And over the years, endoscopy itself has changed. There have been some advancements and breakthroughs. Most notably, in 1957 was when the breakthrough in the field of fiber optics came to light, and Basil Horschowitz applied those principles of fiber optics to develop the first prototype of the gastroscope that we know today. And interestingly, he actually passed it into his own stomach to see if it worked. So this marked the transition from external sources of light to internal sources of light and kind of revolutionized endoscopy. But there have been numerous other pioneers in the field of endoscopy and surgical endoscopy, including Dr. Jeffrey Ponsky, who is a pioneer of the percutaneous endoscopic gastrostomy in 1979. He's also served as president, chairman, and vice president of numerous different societies and has won numerous prestigious honors, including the ASGE's Rudolf Schindler Award, which is the society's highest recognition for awards and excellence in endoscopic research, teaching, and service. So his contributions and the contributions to other physicians in the field of modern endoscopy have led us to where we are today. And there is a vast array of advanced endoscopy that can be done. And this list that I'm going to show you is not inclusive, completely inclusive, but we're talking about endoscopic ultrasound, ERCPs, balloon enteroscopy and ablative techniques, stenting, stricture dilation, mucosal and submucosal dissection, and luminal closures. And the list goes on. Everything from the percutaneous endoscopic gastrostomy that we talked about previously, the POEM procedure, plus or minus use of a fundoplication with that, the transoral incisionless fundoplication, the TIF, and then again, radiofrequency ablation. And there are now several endoscopic anti-reflux and bariatric procedures that are being performed. And one of the more well-known uses of advanced endoscopy for this and for the treatment of obesity is with the intragastric balloon placement, which kind of leads us into talking about our first case report. So let's first, when we were doing this case, actually intragastric balloons was kind of a new thing for me. I hadn't really heard about them. So it was very interesting to do a little bit of research in the different types of intragastric balloons. And Dr. Pryor, in talking to her, said that actually some of these balloons are not readily available on the market still because of potential complications and issues. but some of them still available throughout the world. So, it might be good to know they still exist, but there are quite a few. And here I've kind of given you a description of how the balloons sit within the stomach. And over here, the different types of balloons that they have, what their normal filling material is. All the ones that are filled with saline include methylene blue as an indicator for balloon rupture or leak. What the duration of implantation is estimated to be, and how they are actually implanted, either swallowed or placed via EGD. And on the spectrum of bariatric procedures, the gastric balloon actually kind of falls before even what the gastric band, which is relatively archaic in these times. But the minimum BMI it's actually in Europe is about 27. In the United States is 30. But for patients that do not meet criteria for other types of bariatric procedures, expected weight loss with the gastric balloon can range anywhere between 20 to 40 pounds. And again, this is a temporary technique. And there are some absolute contraindications to intragastric balloon placement, which include prior gastric surgery, coagulopathy, severe liver disease, any type of upper GI bleeding, or a history of ulcers, pregnancy, alcoholism, drug addiction, and hiatal hernias that are greater than 2 to 3 centimeters. That will become important. So the way that the intragastric balloon is actually placed is an endoscope is inserted with the balloon kind of attached to it down into the stomach, where under direct visualization, the balloon is then inflated with its component of choice, whether saline, methylene blue, or air. And this kind of restricts it's a restricted procedure for anything going into the stomach. And in the event that the weight loss is completed, or the time frame is completed, another procedure goes and deflates the balloon, which is then retrieved by a grasper via the endoscope and removed from the patient's stomach. So after a little bit of history with the gastric balloon, we'll move into our first case report. So case report number 1, LW is a 68-year-old female with a past medical history of GERD and known 5 to 6 centimeter hiatal hernia, and a past surgical history of ventral hernia repair, C-section, hysterectomy, and cholecystectomy. She took omeprazole once a day for GERD, and she reported that did resolve her symptoms. She had the Orbera gastric balloon placed in July of 2022 due to a desired weight loss of about 20 pounds. And immediately following the procedure, she began having issues with epigastric pain, nausea, vomiting, and diaphoresis. She was discharged that day from the procedure, but the following day presented to the emergency department because she was continuing to having these symptoms of epigastric pain, nausea, vomiting, diaphoresis. At that point in time, they obtained a CT chest, abdomen, pelvis, which demonstrated the following. So for the fellows online, what exactly do you see?
So we'd like you guys to volunteer. You can use your reaction button and raise your hand if somebody wants to chime in, and we'd love to hear your ideas on what you see on the scan and potential management. Nice job so far, Cecily.
Thank you. Oh, thank you, Dr. Benzie. Yes, please, everyone join in. This is going to be very interactive. And I left this open-ended because I really want people to kind of, kind of free-form what your thoughts are, because when we see patients, it's a lot of times not a multiple choice answer, right? We have to kind of come up with these things on our own. Anyone want to venture a guess?
And if nobody volunteers, I'm really happy to pick on some folks. So.
Yeah, I was just thinking, I'm going through the list of participants, so somebody please speak up. Otherwise, we're going to get called.
Sorry, I just didn't know how to raise my hand.
Okay.
Neither do I.
Sorry, my name is Aziz. I'm from Miguel. So probably the balloon is probably this patient had like a diaphragmatic hernia or like a paraesophageal hernia, and the balloon was insufflated above the diaphragm level, which gave her the abdomen pain. Could see some, I'm not sure if that no, I wouldn't call it nematosis in the gastric wall, but I would call it like an insufflated balloon above the diaphragm level. If this is like a balloon that require to be desufflated through an endoscopic procedure, this patient will need like an urgent endoscopic desufflation of that balloon.
So if you want to do that, when do you want to deflate that, or do you want to try any other maneuvers first?
I mean, probably these balloons, after you insufflate them, you have no access to reduce the amount of fluid inside. Yeah, if I feel this patient like is hemodynamically stable and she is like she's not sick, I would like scope her in the like in the endoscopy unit. If this patient like showing any signs of gastric ischemia or the patient is sick, I would take her to the operating room and scope her in the operating room.
Anybody else have a different opinion? How urgent is this? Did you do this right after the CT as soon as you get the results, or something else? She's having epigastric pain.
I would call it urgent. Like it's like an incarcerated gastric hernia. Like
Right.
I
Thank
would
you.
call it urgent. Yeah.
Yes. All right, so actually they did remove the balloon at that time. They desufflated the balloon, and an EGD that was done at the time of desufflation demonstrated these findings. So how would you manage that?
So can we get somebody else? You did a great job, Ali, but we need to get somebody else to chime in.
And I'll go back so you can kind of take a peek at what we're looking at.
I'm going to ask Dr. Zalewski. Alicia? Oh, I don't think she's on. How about Dr. Pondadure?
And if we call on you and you're the attending, you feel free to punt the question over to your fellow. Anna Rivera.
Yes, hi. Well, the stomach is ischemic, so I think if the patient is unwell and has like elevated inflammatory markers, we should go to the OR and do maybe a partial gastrectomy. But it's a little bit far up, but I think it's an urgent matter that we go to the OR.
Does anyone have a different opinion?
Hey, this is Loan from Princeton. I think after we did the deflated balloon and just looking at the EGD findings, I think I would do a period of observation and see how she does the next 12 or 24 hours. See her abdominal exam, and of course, checking her inflammatory markers. And if she's doing okay, you're really questioning, is this like a trans mirror necrosis versus just the inner lining of the stomach, and maybe this will get better in the course of time. It's hard to tell with the picture on the left, but the picture on the right looks more just in necrosis in the inner lining. Yeah, that's what I have.
I have a question. Do you have fluorescent capability to check for blood flow at this point?
This was done at an outside facility, and I'm not sure exactly what their capabilities were. But that is something if you wanted to do. I don't know that I read anything about that as a potential. Maybe the attendings can give some feedback as to if they've ever done that to assess for viability.
I don't know if you can do that endoscopically, but a diagnostic laparoscopy with using that to assess perfusion, I think, is a very reasonable maneuver at this point in time.
Dr. Pryor, would it be okay if we asked Dr. Lin, since he's on, Ed Lin, for your comments, Ed, on this? It's great to have both of these leaders in bariatric surgery on the call. I mean, Aurora and Dr. Lin. Ed? We can't hear you, Ed. Okay, I guess we'll keep going. Hopefully we can figure out something. Sorry.
Well, and I think that all of these are good, great potentials. And so the way that they chose to manage this patient was to place her back on her PPI. And as she started to have resolution of her symptoms, they advanced her diet back to a regular diet. She remained in the hospital for 7 days, but after discharge, she started having again issues with PO intolerance, reflux, nausea, and vomiting. And on the 25th of July, returned back to the emergency department with an acute worsening of her pain, nausea, and PO intolerance. And at that time, a CT abdomen and pelvis was obtained, which demonstrated, of course, her hiatal hernia with fluid distension, mild wall thickening, and fluid in the distal esophagus. Also some mild wall thickening and irregularity of the proximal stomach and perigastric fluid. Unfortunately, I don't have those images because, again, it was done at an outside facility. But at that time, she was provided with symptomatic treatment and discharged home with a planned follow-up with her primary care provider. She continued to have issues and then followed up with her primary care provider, who ordered an EGD to evaluate for resolution of her issues. And when she had that EGD completed on August 16th now, it showed gastric stenosis. And it was at this point in time that she was referred to us and transferred on a direct admit to the hospital, to Methodist Richardson. So this patient comes to your hospital. How would you like to initially work her up?
Dr. Ed Lee?
Yeah, I'd get an upper GI just to look at the degree of the stenosis and also look at how it transits through the stomach and the esophagus.
Okay, and that's great. We actually did get a chest, abdomen, pelvis. If anyone is interested in trying to take a read at this, I slow down at the interesting parts.
Dr. Hassan?
I'm a colorectal surgeon, but I'm happy to read it just for kicks and giggles.
Or you can pull on your fellow if you want.
I'm representing the board, so I don't really have a pillow here with me, but I can pick on somebody else.
Sure.
I can go at it. This is Andrew Gazowski. I'm a fellow at Advent Health.
Thanks, Andrew.
Yep, no problem. I see esophageal thickening with fluid, and worryingly a left-sided pleural effusion, concern for, esophageal leak. But I don't see like a frank disruption or anything like that in the images that we can see here.
Okay. So this area right in here was red, concerning for, of course, her hiatal hernia with mural thickening of the herniated portion of the stomach and a perforation at the left lateral aspect of the intrathoracic stomach with associated esophageal distension. And again, like you said, moderate sized left pleural effusion. And we did also proceed with the upper GI as you suggested, which demonstrated a flame-shaped small collection of about 1.3 centimeters by 5 millimeters of this extraluminal contrast from the left side of her hiatal hernia that was consistent with a small leak. So now you know there's a perforation. What are your management options at this point in time?
So the pleural effusion needs to be drained for source control. And then I think you can talk to other people, experts, in terms of possibly putting in a stent.
Okay. So I divided this up into options for non-operative management and options for operative management. So non-operative management, like you said, stenting and drainage. And I think there are some cases where non-operative management is recommended. And I'll get kind of more into that with the second case report. And then, of course, there's the option for operative management in this patient with varying techniques depending on what your findings are. Based on the fact that the patient was progressively symptomatic and was visibly uncomfortable, she was stable from a vital sign standpoint, but this had been ongoing for over a month, and there was a lot of concern for this perforation in her into her chest, and it being at the GE junction or kind of close to the GE junction. So we actually opted for operative management. The day after she arrived and after we saw all of the imaging, we took her to the operating room where we performed an exploratory laparotomy, which included a xiphoidectomy to get up into the area where we needed to operate. We reduced the paraesophageal hernia from the chest, and we were hoping at that time that we would just be able to either kind of staple off and do a subtotal the portion that was perforated in the chest, but unfortunately, once we had everything kind of mobilized, we saw that there was just kind of gross necrosis of the GE junction and the proximal stomach. And so we ended up having to do a distal esophagectomy and proximal gastrectomy with a Roux-en-Y esophagojejunostomy. We did place a left chest tube placement intraoperatively for drainage of that effusion. And then we placed a gastric tube in the remnant stomach. Once we closed her, we placed a Pravina incisional wound back. So her post-op.
So I'm going to interrupt for a second, Cecily, because there's some comments in the chat that I think are actually pretty interesting.
Yes.
One is commenting on, would you stent with the presence of a paraesophageal hernia? And I think that is a really interesting point. I think some of the problem with this necrosis actually came from the wall force of that balloon at the diaphragm hiatus itself. So stent could set you up for part of that problem again, although they are smaller. And it might essentially bounce back up and down a little bit and not seat well, as Rohan pointed out in his comments too. So both of those are real, but it's stent's a consideration, particularly if somebody's sick. If you got source control, I think that could be something temporizing. But I do like how you guys did the Roux-en-Y esophagojage for your weight loss procedure in addition to your paraesophageal hernia.
Benefit, she wanted to lose some weight, so here she goes.
Right, yeah, there you go. She got a better procedure than a balloon.
Right, she got the procedure she wanted.
Dr. Stuka, do you want to comment? You have your hand up.
Yeah, I had a quick question, and I think this is a very interesting case so far, and I think that ultimately it sounds like the surgical management was appropriate. I just wanted to ask two quick questions. The first was that initial CT scan, when you're on the coronal section, there's a little dot of air in the left upper quadrant of the chest where this perforation ultimately ended up being. Is there any evidence on that initial CT scan that there may have been a perforation at that time? And along those same lines, you sent her home with a regular diet. My question is do you think it could have been a little bit more prudent to maybe try and do a PEG at the same time and just drain the stomach to maximize the ability for the stomach to sort of decompress and kind of recannulate some of those necrotic vessels? Was there any discussion of that at the time of the first endoscopy?
So the first endoscopy was done at an outside facility. She didn't get transferred to us until there was evidence of gastric stenosis, and this had all kind of been more or less a month out from her initial balloon placement. But I agree, at the first CT scan that we see, it does look like there's little foci of air concerning for a perforation. I don't think that they saw that on endoscopy when they removed the balloon, and I think that with their conservative management, when she started to improve somewhat, they thought that it was self-limiting. I don't know, I didn't speak to the surgeons at the other facility, but yeah, I think that you're correct in that the management, had she been at our facility, would have potentially been different.
Dr. Lynn?
All right, I got it to work. So did anybody think about proximal gastrectomy and esophageal gastrotomy?
So I'm going to take that question, Dr. Lynn. I think that's a really good question. The thought there is, if you look from the cancer world, Dr. Lynn, the problem is the bile reflux with these patients, because you've got to do a pyloroplasty in that circumstance. And so when I do esophagectomy, I'll pull it up to the neck and keep the pylorus at the hiatus, which I think really acts as a good reflux valve. But when you straddle the hiatus, I think it's miserable for these patients. So I favor, and literally we make this rulum like 75 to 100 centimeters long to try to prevent bile reflux in these patients. So that was our thoughts, but I'd really appreciate your input on that. Are you a fan of that, Ed?
No, I see that done more and more around the world, and including some of our thoracic guys, which is, I don't think it's wrong in a bailout procedure. You know, you just have to get the heck out of it. But I think what Dr. Jayarajan is saying is really key for everybody. You may have saved the day, but the bile reflux will be really miserable, or even the reflux, not even just bile. The dysphagia is it's almost like the initial picture that you guys showed, where this balloon straddled the hiatus. So you have to think about, if you're going to do that, fine, save the day, but long term it may be more miserable. You probably should have just, if you want to do something like that, Ivor Lewis. But I can see people doing a bailout procedure for things like that.
Dr. Hassan?
So, Sunil, I know you mentioned that you do not manage the first event, but in hindsight, so I'm on call tomorrow here. What should have been done, or what do you think would the option, instead of just observing it and then discharging the patient? And you said it may have been done differently at your institution. So the first time around, what would you have done, or what should be done, do you think?
Yeah, I think that initially when the patient came back after removal of the balloon, or even when she was in the hospital after removal of the balloon while they were managing her non-operatively, I would have liked to have done an upper GI to ensure that there was not a leak at that time. From everything that I found, that wasn't done. And I think that would have been an important step to make sure she didn't have a leak, or at least a PO contrasted CT, and I didn't see any record of that in the records that we could find from transfer over here. So those would have been my initial steps to ensure she wasn't leaking, and then I would keep her on the PPI. I don't think I would have advanced her diet as aggressively as it sounded like they did. It sounds like they, within a 7-day course, had her back on a regular diet. And then she had been doing fine, and then once she left the hospital, came back with similar symptoms. So I think that may have been a little bit aggressive advancement for her.
So I'm also going to point in that counterpoint that I think a diagnostic laparoscopy would have made sense. You saw that waste pushed on that balloon from the diaphragm. That means it's putting in a fair amount of force on the tissue that's sitting right in there. And it was pretty significant ischemia from the mucosal surface.
Yeah.
So once you have a complication, do the safest thing. And I think the safest thing at that point is not non-operative management. It's let's look and make sure it's not transmural, because I mean, she probably would have ended up essentially with the same management you had, but it would have prevented the pleural effusion potentially and some of the sequelae that she would get from that.
Yeah.
All right. Do you want to keep going? Or any other questions or comments from the group? Lead on, Dr. Dupre.
Okay. So leading into her post-operative course, she actually did relatively well post-operatively. Post-op day 1 through 4, we kept her on her PCA. She had an NG tube to low intermittent wall suction. We had her on TPN for nutritional support. We also started tube feeds via her gastrostomy tube, which she tolerated well. And the chest tube was initially to wall suction. On post-operative day 5, we obtained an upper GI. which is seen here, initially, interestingly, was read as a potential leak. And I think that if you wait for the contrast to evacuate from the esophago-J, you can see there's kind of a faint haze back here that I think there was concern for a little bit of a leak, but we had a subsequent CT scan that confirmed that there was no leak. You can see it kind of lingers, and they noted, see that kind of lateral haziness. But in reviewing the film with the radiologist, we all kind of determined that it was probably just the end of the loop of jejunum that was kind of holding the contrast there, and the follow-up CTs confirmed that. And so post-operative day 6 through 8, we were able to advance her diet, remove her chest tube, start her on all of her oral medications, and she was discharged on post-operative day 8. So I did find a couple of different articles on the use of these intragastric balloons that I want to kind of talk about. This was a longitudinal study that compared close to 6,000 patients that underwent intragastric balloon treatment in clinics in Brazil from 2009 to 2017. Their inclusion criteria were adult and elderly, with a BMI greater than 27 that had failed clinical weight loss and did not qualify for other types of bariatric surgery. They also had some exclusion criteria, primarily any of the contraindications to intragastric balloon placement. They noted that the incidence of complication was about 7%, with 6% of that being early balloon removal. And that was typically due to intolerance, which was similar to other studies that were done. Balloon leakage, hyperinflation, which was another common issue with the intragastric balloon, and issues with vomiting, that type of thing were more of the primary reasons. There was also leakage in a small percentage. A couple of patients got pregnant. Gastric perforation was noted in less than 1%, and upper GI bleeding. So because of this study and that it did not seem like there was a very high rate of termination, and the average weight loss was one that was comparable to other studies, they determined that intragastric balloon placement was safe and effective for weight reduction, and that mortality and morbidity was very low in this large kind of patient population. So that was kind of the pro that balloon, that this is a successful weight loss with very low morbidity and mortality. Now, in contrast, I found a few other articles that the first one on evaluating the safety of the intragastric balloon. This was an analysis comparing the intragastric balloon to laparoscopic bariatric surgery as far as complication rate. And they found a very significantly high rate of non-operative intervention associated with the intragastric balloon placement. In fact, a 4 times higher non-operative reintervention rate. Reintervention was anything summarized from early removal to need for diagnostic endoscopy due to persistent symptoms, the need for placement of an IVC filter, pure cutaneous drainage, and other things because of nausea, vomiting, types of intervention. So overall, they found that there was a statistically significantly higher complication rate in the gastric balloon. And then specifically the study examining the Barrett 365 intragastric balloon also showed similar complications and overall higher than expected complication rate of 23.7%. Interestingly, and as I was looking, and Dr. Pryor, maybe you can comment on this, because as I was reading a lot of different papers regarding pros and cons about these intragastric balloons, I also saw that pancreatitis was a fairly repetitive theme as far as complications go. So I thought that was kind of an interesting thing as well. But the majority of the complications that I saw were intolerance of the balloon. That was the highest one. And then, the actual perforation, having, pancreatitis and ulceration were kind of bringing up the rear.
Yeah, so I think the acute presentation of complications, you've got a nice one with the hiatal hernia, which I honestly think was a mistake in placement because the hernia was big enough, they shouldn't have put the balloon in. The other one is the hyperinflation. So if you ever get imaging, even just a plain film that shows air inside a balloon with an air fluid level, that's not normal. So that's an at risk for hyperinflation. That balloon should come out. And then a deflated balloon might be a surgical emergency that's presenting remotely from where they were placed. Pancreatitis, if that happens, that's thought to be a pressure effect. And from the weight of the balloon, these are heavy balloons where they're full of fluid. And if you're lying and putting that pressure on your pancreas all the time, particularly on your spine, that could lead to that. So again, those are patients that those balloons should come out early. But if you look at bariatrics in general, we're only treating, under 2% of the people who qualify for weight loss, and there's definitely medical benefits for weight reduction. So I still think there's a place for balloons in our practice, and we just have to be aware of the complications and look for how to manage them.
Yeah. All right. This is one of my fur babies, Kane, and at this point in time, for the first case report, does anyone have any questions or anything we'd like to kind of go back over? If not, I'll move on to our next case. Okay. Our next case report, this is DP. She's a 41-year-old female with a past medical history of hypertension, diabetes, and GERD. She had a past surgical history of a paraesophageal hernia repair with a toupee and underwent the Halo RFA for a long segment Barrett's esophagus in July of 2022. At the time, and I know it doesn't seem like it makes sense, and we'll go into the algorithm, but at the time she was found by EGD to have low-grade dysplasia. And that was the decision to undergo ablation. And we'll get into new recommendations based on low-grade dysplasia. But first, let's review Barrett esophagus. So this is our interactive part. So everyone get ready. We all know Barrett esophagus is the metaplastic columnar epithelium that replaces normal stratified squamous epithelium of the distal esophagus. But can anyone tell me the designations of Barrett's esophagus? Or maybe I'll start off by saying you have segments. So what is the distance that qualifies all of these different segments?
Who are the MRMC fellows?
That's our group of medical students and all sitting in there.
They might know.
Do any of you guys know? Want to speak up?
I'll take a wild guess. 3 centimeters. 3.
You got it. Very good. So
Strong
a long,
word.
that's kind of your cutoff, right? So a long segment is going to be greater than 3 centimeters in length. And so by kind of default, a short segment is going to be less than 3 centimeters. But then, and I actually didn't know this until I started researching it, they also qualify an ultra short segment, which is less than 1 centimeter with microscopic intestinal metaplasia at the cardia. And so, we've talked for a long time about surveillance in Barrett esophagus and chronic GERD. And this is kind of a good algorithm for, how to manage Barrett's esophagus and whether or not you have dysplasia when you have your surveillance EGDs. And, I think the no dysplasia and the high grade dysplasia are kind of automatically, of course, we know what the treatment algorithm is. But the low-grade dysplasia has kind of been a gray area, and over the years, there's actually been a change in dogma for management of low-grade dysplasia. And in fact, this is a really great review that goes over the current management of low-grade dysplasia that suggests there's an increased risk in progression of low-grade dysplasia to high-grade dysplasia or adenocarcinoma, especially when they've had multiple biopsies and multiple, different pathologists have confirmed the diagnosis of low-grade dysplasia. So in this setting, level 1 evidence actually supports endoscopic ablation as a viable treatment option for these patients, and that's actually recommended therapy at this point in time. So with that being said, our patient with low-grade dysplasia, instead of following the central algorithm, she actually kind of jumps over here into the no mucosal irregularity, and so you treat based on the patient's preference. And based on her repeated EGDs, it was recommended that she undergo radiofrequency ablation, and so she did. I'm losing my hair gum.
The other thing that's missing in your algorithm is a discussion of how you manage the underlying reflux, right? So, as surgeons, we think these people should actually be referred for surgical therapy too.
Yes. Yes, exactly. And kind of thank you for sending me back to this slide, because I kind of wanted to go over the different radiofrequency ablation. The one that we're going to be talking about is the Halo RFA. Halo RFA is in 2005, it was a system that was approved by the FDA for Barrett's esophagus and patients who had dysplasia and who qualified. This uses radiofrequency ablation to destroy the tissue. And there have been numerous studies in both the United States for evaluating eradication rates. And in fact, in the most recent peer-reviewed medical literature published, eradication rates of a complete treatment course of radiofrequency ablation range anywhere from 72 to 100%, with most of them reporting greater than 90% eradication rates. So how does Halo RFA work? Initially, so there are two different types. You have this Halo 360, which is a 360-degree catheter that can be introduced, and this will give you a circumferential ablation, or you can mount the Halo on this kind of 90-degree, it's a Halo 90, and this is a very directed pinpoint ablation. For Barrett's, the Halo 360 makes the most sense and is most commonly used. So over here in these pictures, this is kind of the ablation, and then you can see the introduction of the Halo 360 balloon, just past the lesion. And then in the top corner, down here, I'm sorry, in the top corner is the immediate after effect after the first ablation. You can kind of see that this kind of pale tissue. And then after removal of the balloon down here, you can see that there's necrotic debris. And then they irrigate it several times to wash off the necrotic debris. And this is kind of the result that you see. And then this is the follow-up EGE 8 to 12 weeks later. So, and then they continue with initial surveillance to ensure eradication rates. And then from then on, it's just regular surveillance. Now, with any procedure, of course, there are complications, and Halo is not unique in that. And there are some pretty serious complications that can occur, including stricture, bleeding, and perforation. Those are the most serious complications that can occur. And but there was a nice study out of the UK, which was a 10-year review of about 2,500 patients at 28 different sites that were performing this Halo RFA. And they assessed for rates of invasive cancer and looked at the analysis and showed that there was a reversal of dysplasia in Barrett esophagus with the RFA that reduced the cancer risk by 90% compared with historical data of about 6 to 19. So it showed that there were some long-term benefits in radiofrequency ablation for reducing rates of cancer. So this patient, back to the kind of the patient, she had her Halo RFA, but then developed some dysphagia following her RFA. And so an EGD was performed that showed mid-esophageal stricture that was reportedly very tight and didn't allow passage of the endoscope, but it did allow passage of a dilation balloon, which was then used to sequentially dilate the stricture up to 8 millimeters, at which point it was terminated because they noted significant resistance at the 8 millimeter mark. There was also time at the time there was concern for perforation because there was one area that looked like it had a tear in it. And so they placed endoscopic clips at that site and terminated the procedure. And then immediately upon recovery from the procedure, the patient was reporting severe chest pain, which was fairly unrelenting. And so at the time, they obtained a CT after the procedure. And again, if anyone wants to jump on this and walk us through this CT scan.
All right, how about Dr. Vidagliano?
Hello.
Are you ready? You're ready. You got this. All right, so here. And let me know if you need me to stop or back up. So what are you seeing?
The aorta is enlarged. The ascending and descending aorta is large. There's a cardiomegaly.
Is there anything that you see in this area that from the EGD might clue you into the location of where we are at this point on the esophagus?
The hyperdense object in the esophagus.
And so what do you think that that is? Those were the metallic clips that they placed at the time of initial dilation. So you know that's kind of our area of concern, or at least adjacent to it. And then as we continue to track down, there's the arrow sign. What is that we're looking at?
Is that the GE junction?
So here's stomach, GE junction, just proximal to GE junction.
Does anybody want to help him phone a friend?
Looks like air outside the esophageal lumen and with pleural effusion concerning for perforation.
Exactly. So this was measured at 4.3 by 2.3 millimeters, posterior mediastinum, posterior to the esophagus, concerning for a contained perforation. Good. Thank you all for participating. All right. So as an aside, I have a bonus question. The triad of vomiting, chest pain, and subcutaneous emphysema as a presenting symptom in approximately 27% of patients with an esophageal perforation is known as what? And I think anyone can join in on this, including our attendings.
Let me Google it real quick.
You don't win anything other than pride.
Mackler's triad?
It is the Mackler triad. Very good. Who was that?
Kat Fay from Emory.
Nice. Excellent work. Okay, so for extra credit, there is an even less common triad of subcutaneous emphysema, tachypnea, and abdominal rigidity. And what triad is that?
Oh, that I have no idea.
Does anyone know? That one might be tougher. That's the Anderson triad. So just something to keep in your wheelhouse in case you hear it in conversation. This patient didn't really have that, but I thought that was really interesting that there are these described triads in association with esophageal perforation. So in going back to our patient, now that we know that she has an esophageal perforation post-dilation, what's your next step in management?
Dr. Chow, do you have any ideas?
I think you should maybe try a stent in a chest tube because it should be pretty clean. And the patient just had the procedure very short time ago. And then at least that'll give you a bridge to give her improved nutrition.
Does anyone else have an alternative approach?
How soon after dilation was this found again?
It was immediately following dilation that this was recognized.
So I think that if it was a fresh, discovered perforation, then I would opt for surgical management of this.
Okay. And again, you know, both are neither are incorrect, right? So we go back to non-operative management versus operative management. Now, if this had been actually a perforation that occurred because of the ablation, would that change your management on how you would want to do this? Would you switch from doing non-operative to operative or operative to non-operative, or how would you approach that? Or would you do anything different?
I think it was immediately after ablation, then it's a much more significant thermal injury. I think you would probably lean toward operative, but I think from dilation, I would maybe lean toward non-operative.
And the important thing to point out is if you're stenting, you also have to control the infection, which you mentioned, but that's really, part of that procedure. The other thing is if it's been a contained perforation that's been there a little longer, you can also consider endovac, but that's not really exactly right for this case.
So, and I would love some expert opinion on this because I was, in making the kind of in thinking about decisions for management and the research that I did, there were two different schools of thought, and one was a little bit more non-operative and attempting non-operative management as much as possible, including especially for like a mild, what they called a mild injury, attempting PPIs, esophageal rest, doing alternative feeds through like TPN, and then if deemed appropriate to do stenting and drainage. And a lot of people were kind of talking about more conservative, non-operative management of these types of perforations with that. But then when injuries became more severe, or there were associated findings like, effusions or concern for infection, then moving on to things like the operative management with esophagectomy, primary repair, diversion, things like that. So how would everybody kind of approach this as far as, your options for operative versus non-operative management?
So for me, I'm sorry, I cut somebody off, but I saw the CT scan. I thought this was one big hole that you were not going to just be able to sit on, but I could be wrong.
Yeah, I would have taken them for endoscopy following that and looked at it. And if it was a small hole, which it looked like it probably was because they thought it was just something they could clip, then I think stenting is actually pretty reasonable. If you found a giant hole and the tissue looked terrible, then it's not going to work. But so you could start your operative procedure with the endoscopy and stent as an option, but divert from that if need be.
Sorry, Dr. Pryor, when you say divert, are you talking?
Change your treatment plan. Yeah.
Oh, I thought you meant like cervical.
No, not a diversion, not a surgical diversion, except for like making a different kind of incision or access. Sorry, that was a confusing term.
Okay, well, is there any other recommendation from our experts?
Can we ask Dr. Ross? You've been really quiet and you're like such a renowned person in this area.
Thank you. I thought that was excellent discussion. So I would usually, especially if I don't think there's a big perforation, now they do more stents. And if there's a pleural effusion, any risk that there's a spillage and the stent just might not cut it, then I would kind of take it for drainage, wide drainage, make sure, and of course robotically, make sure that everything is washed out and place some drains and then just watch. Not unless it's like easy to fix primarily, I would just sit on it. But stenting has been a real shift toward esophageal stents. Before in the past, we used to rush them to the OR. We no longer do that. And we avoid many operations just with stenting. So it's mostly endoluminal treatment.
And Dr. Pryor, we're going to need to finish up pretty quickly, but I just wanted to ask, I mean, this is a really long segment stricture. I mean, it's carina down to the hiatus. Is that, I mean, apart from the damage control issue, what's the long-term plan over here, Dr. Pryor? Because she couldn't swallow before they were trying to dilate her.
I mean, she may fail, but you don't burn many bridges by trying a stent and seeing if it works. And then if it doesn't, you're still back at your esophagectomy. But I kind of think, you know, it's a no harm, no foul kind of situation. If you can get through that and potentially avoid a bigger operation, I think it's better. So that would be my treatment plan, but that doesn't mean that's the only one. And that's definitely newer and more avant-garde.
You know, and that's the whole point behind this, to learn from each other. So I really, really appreciate this.
Can I just expand on that question real quick, Dr. J. Raja, just sort of to everyone? What's people's sort of lower limit of esophageal stenosis for placing a stent, you know, in this situation or another? You know, you said earlier, Cecily, that the patient couldn't be dilated more than 7 or 8 millimeters. So is a stent even going to fit to some extent, you know, with a smaller stenosis?
So in my practice, treating that kind of stricture, I'd try dilation using Kenalog, you know, serial dilations. But if it keeps coming back and it's tight, then I actually stent for stricture. And I find that's pretty effective. You just realize that there could be some pressure necrosis. Don't keep the stent longer than a couple weeks if you don't have to. That's sort of how my practice is for that. But we're going to go let you, Cecily, just finish up, burn through the last couple slides, because I do
have a couple more to go.
Yep.
So great discussion on the options there. We opted for operative management. We started with a robot-assisted laparoscopic transhiatal esophagectomy and did a cervical anastomosis, placed a J-tube for feeding access later. And you can actually see here's this endoscopic clip right there, and the large disruption of the esophagus right in here. So it was a pretty substantial size. Post-operative day 1 through 4, again, she was maintained on PCA for pain management. NPO, we had an NG tube bridled to low intermittent wall suction. And then on post-operative day 5, we obtained an upper GI, which you can see here very quickly, runs through very quickly, but you can see right down without evidence of leak. And so at that point in time, her NG tube was removed and we started her on clear liquid diet. On post-operative day 6, she was advanced to full liquids. Her JP was removed and she was discharged to home on a full liquid diet and did well post-operatively. So this one is new. Any questions about the second case? I know we've kind of talked about them as we've gone through. So I'll just kind of finish up with
what did you do did you do any pylorus or drainage procedures with your esophagectomy?
We did a pyloroplasty. So, yeah.
Dr. Lin, just old school here. I still do a Heineke Makelitz pyloroplasty. I'm always really concerned about an outlet obstruction that leads to the blowout of the neck, and we routinely go to the neck here. But I know there are people that do Botox or just crush clamp or a myotomy. I seem to always get into the mucosa when I try myotomy.
Any thoughts about the old-fashioned T2 closing flapping? This is a big hole. That was a big hole, right? Any thoughts about closing around a T-tube if we want to really go old school?
You know, I sort of say for diverticular or like a fishbone perforation or something like that, with a more kind of contained, smaller track with more of a cavity outside that I'm trying to kind of deal with. But I don't have a ton of experience. I don't know if anyone else does.
Well, great job. I think we should all give a big round of applause to Dr. Dupree for her amazing presentation and prep. And thanks. Nice seeing everybody and great discussion.
Thank you all so much. It was a pleasure going first, and I look forward to participating in the upcoming lectures as well.
Dr. Benzie, you want to wrap us up?
Sure. Thank you, Dr. Dupree. Thank you very much, Dr. Parr, and everyone that's here participating today, as well as Dr. Jayaraja, our, ACRO moderator extraordinaire. Stay tuned because next month and every month ongoing, we will have these. So check your emails, check your Zoom calendars, and thank you so much for the turnout tonight. This was great.
Thank you all.
Thank you.